Welcome to MedNexus. Okay, let's dive right into this explainer and decode one of the most debilitating autoimmune conditions we encounter in medicine today, rheumatoid arthritis. If you're a medical learner, a healthcare pro, or really just someone fascinated by how the human body works and sometimes turns on itself, you are absolutely in the right place. We're going to break down this complex pathology step by step. Imagine waking up every single morning with painful, stiff joints. Your hands are slowly becoming deformed, and your own immune system has literally mistakenly declared war on your body. Listen, this isn't just your everyday joint pain, and it's definitely not the normal wear and tear of getting older. This is a relentless, systemic condition that completely alters a patient's quality of life. It's aggressive, it's chronic, but as we'll see, understanding exactly how it works gives us the power to fight back. So, here's our roadmap for today. We'll cover the autoimmune joint attack, risks and genetic triggers, how joints get destroyed, symptoms and physical deformities, diagnosing rheumatoid arthritis, and finally, the power of early treatment. Section 1. The autoimmune joint attack. Let's establish our medical baseline. So, the crucial point you have to remember is that this is primarily an inflammatory disease. It targets small joints symmetrically, meaning both sides of the body at the exact same time. We're talking mostly about the MCP and PIP joints, which are the knuckles and middle joints of your fingers, along with the wrists. To break the definition down, it's chronic, meaning it's long-term. It's systemic, so it affects the whole body, not just isolated spots. And of course, it's autoimmune. The real hallmark here is inflammatory synovitis, where the lining of the joints becomes incredibly inflamed. It's a fiery, inflammatory process, completely different from the mechanical wear and tear you'd see in osteoarthritis. Section 2. Risks and genetic triggers. So who actually gets this, and why? There's a really powerful genetic concept at play here. Having the HLA-DR4 marker combined with an environmental trigger, like smoking, drastically increases your risk. Demographically, we see this predominantly affecting women, usually showing up between the ages of 30 and 50. But the genetics are where the story really gets interesting. If you have that HLA-DR4 gene, your immune system is essentially primed and waiting. You add a trigger like cigarette smoke or a certain infection, and boom, you light the fuse for a massive autoimmune cascade. Section 3. How joints get destroyed. This is the ticking clock of the disease. Let's look at how that genetic vulnerability turns into physical damage step by step. First, that trigger we just talked about activates the immune system. Then T cells, B cells, and macrophages basically storm into the synovium. They release major inflammatory signaling proteins called cytokines, specifically TNF-alpha, IL-1, and IL-6. We call this the cytokine storm. This constant, relentless inflammation leads to step 3, the formation of something called a pannus, which ultimately results in step 4, the complete destruction and fusion or ankylosis of the joint itself. Now, if you're a medical learner, committing the definition of pannus to memory is absolutely essential. This tissue is the primary villain, destroying the cartilage and bone. Think of the pannus as this angry, overgrown, tumor-like mass of granulation tissue. It doesn't just sit there benignly. No, it actively invades and eats away at the underlying cartilage and bone. It's kind of like a creeping weed that just chokes out the healthy joint structure. Section 4. Symptoms and physical deformities. Let's talk about what living with rheumatoid arthritis actually looks like for the patient. Okay, here is a massive clinical pearl for you to remember. The number one symptom patients will present with is morning stiffness that lasts for more than 1 full hour. This is an absolute classic hallmark. When they wake up, their joints are incredibly stiff because inflammatory fluid has pooled in those areas overnight. It takes them well over an hour of movement just to loosen up. That is fundamentally different from mechanical joint pain, which usually gets worse the more you use it, not better. And here's a brilliant way to illustrate the key difference for your differential diagnosis. Rheumatoid arthritis characteristically spares the DIP joints. Osteoarthritis loves those joints, the distal interphalangeal joints, the ones right near your fingernails. But RA, it almost entirely ignores them, focusing instead on the knuckles and the middle joints of the fingers. Spotting this physical difference is an absolute game changer in the clinic. As that joint destruction continues unabated, patients develop highly specific, characteristic hand deformities, along with these subcutaneous rheumatoid nodules over their pressure points. Because the ligaments and joint capsules are literally being destroyed by the inflammation, the tendons pull the fingers into bizarre shapes. You'll see ulnar deviation, where the fingers basically drift outward toward the pinky side. There's the swan neck deformity, where the middle joint bends backwards while the tip bends down, and the boutonniere deformity, which is the exact opposite. And let's be clear, these aren't just cosmetic issues. They severely compromise how the hand actually functions. But remember what we said earlier. This is a systemic disease. The attack reaches far beyond the joints. It goes into the lungs, where it can cause pleural effusions or interstitial lung disease, and into the heart, causing pericarditis. It can even cause scleritis in the eyes or anemia. Also, watch out for a classic triad called Felty syndrome. That's rheumatoid arthritis, an enlarged spleen, and low white blood cells. And critically, RA can cause dangerous atlantoaxial instability. That's a loosening of the joint at the very top of the neck, right under the skull. This is a massive danger during surgery if a patient needs to be intubated, because tipping their head back could literally compress their spinal cord.
Section 5. Diagnosing rheumatoid arthritis. This is where we act as clinical detectives to confirm what's happening.
When reviewing the lab work, you'll notice that while rheumatoid factor is often present, it can actually be positive in other conditions too. So it's not totally specific, but the anti-CCP antibody, that one is highly specific. If that's positive, it acts as a massive red flag for severe disease, and you are very likely dealing with rheumatoid arthritis. We also look at ESR and CRP. These measure sedimentation and reactive proteins, essentially acting as the body's alarm bells, telling us, hey, systemic inflammation is happening right now. Combining those lab results with imaging paints the full picture. You will typically spot joint space narrowing and marginal erosions. This is a direct radiological reflection of that synovitis we discussed earlier. On an X-ray, that dark space between the bones shrinks because the cartilage has literally been eaten away. You'll actually see what looks like bites taken right out of the edges of the bone. Those are the marginal erosions caused by the pannus. You'll also see osteopenia, which is a thinning of the bone right around those affected joints. Section 6. The power of early treatment. This brings us to the ultimate goal of this explainer, stopping that irreversible damage. While NSAIDs and corticosteroids are great for putting out the immediate symptomatic fires, they don't actually alter the disease timeline. NSAIDs like ibuprofen will definitely help with the daily pain, and corticosteroids like prednisone act like a rapid fire extinguisher for sudden flares. But here's the catch. Neither of them actually stop the pannus from eating the bone. For that heavy lifting, we desperately need step 3, DMARDs. So the crucial point you must take away from this explainer is the DMARD principle. Early intervention is the absolute only way to preserve joint integrity. DMARD stands for disease-modifying anti-rheumatic drugs. The absolute key word here is modifying. They actually change the entire course of the disease. If we hit the disease hard and fast with DMARDs right after diagnosis, we can drastically decrease or even entirely halt joint damage. In this scenario, time is quite literally bone. Methotrexate remains the undisputed heavyweight champion of DMARDs. It's almost always our first line of defense. But medicine has evolved brilliantly over the years. We now have biologics, and alongside methotrexate, many patients achieve excellent disease control. Biologics act like highly targeted sniper rifles against the specific cytokines causing the storm, like TNF-alpha. By blocking those specific pathways, we can completely shut down the inflammation at its source. It's a real game changer. Rheumatoid arthritis is far more than just a joint disease, right? We've seen how a microscopic genetic vulnerability can spark a systemic, life-altering fire, and how modern DMARDs and biologics act as a targeted extinguisher. But it leaves us with a final provocative thought. As these biologics become even more advanced, will we eventually move from just modifying this disease to editing our own immune systems entirely, ensuring the fire never even starts in the first place? If decoding this autoimmune puzzle was helpful, drop a comment letting us know what rheumatology topic we should explain next.